This is QD video brought to you by RheumNow.Live, the next best meeting in rheumatology, February 2019 at RheumNow.Live for more info. I'm Jack Cush. Today's lesson is about what to do with one joint. So I have a patient who I just saw who is 62 years old with seropositive rheumatoid arthritis, RA based on symmetric polyarthritis, high titers of rheumatoid factor, CCP antibodies, previously treated with sulfasalazine, methotrexate, Arava, Plaquenil, and most recently put on prednisone in low doses and Cimzia. She did really well. She's currently taking Cimzia, PRN loading, a little bit of gabapentin at bedtime, not taking prednisone. She's doing great, on a scale of, 0 to 10, she's about a 3 in activity and about a 1 in pain, so she's doing quite well. She only complains of some pain in her right hand. On exam, and the whole of her exam is totally normal with the exception of one joint. In her case, it's right MCP2. It's swollen, it's 2+ swollen. It's really tender when you palpate it or when you manipulate it or when she uses it too much. And the question is what to do about that. In the past, she's had x-rays of her hands showing some erosions. I don't know if it's specifically at that joint, but that was done 2 or 3 years ago. And the question is what to do about it today. So again, patient's well controlled. One time their CDI, or I do a gas score, which is like the CDI, one time was 15, and then with therapy came down to 10, 2, 1, 3, 1. It's been really very low. Today it's a 2. What do you do with disease activity like that? Her labs are normal, or acute phase reactants are normal. She's not anemic. There's nothing else going on metabolically or inflammatory wise. So again, you have certain treatment options. But the first thing I think you have to do is think about one swollen joint. You need to assess that joint, and the general rule in rheumatology is when someone presents with a chronic monoarthritis, you need to go after it. Biopsy it, aspirate it, culture it, look for crystals. Again, chronic monoarthritis can be a crystal-induced arthropathy, can be an infection, could even be a malignancy or something truly, totally unexpected. So when your best therapies are working in everything but one joint, don't think rheumatoid arthritis, think of another disease. Now, if it is rheumatoid arthritis, then I think you need to not just jump in with more DMARDs or escalated biologics. I think you can do some simple things to better manage the case. My first manipulation is immobilization. In the old days, when there were no drugs and it was just gold and aspirin, ask the old guys, they'll tell you they actually used to hospitalize people with very active disease, and that would quiet things down because they would put them at total bed rest. If you immobilize a joint totally, maybe you'll actually have a significant beneficial response. The next approach, of course, would be to inject it locally, and that's based on how skillful you are at that and where the joint is. If it's an sternoclavicular joint or an SI joint, you may not be so enthusiastic about injecting it. An MCP2, most of you should be able to do, especially those of you who do ultrasound. I think that my next approach in someone like this would actually be to add back low-dose prednisone, and I'm talking like 1 to 2.5 milligrams of prednisone might be enough to make a big difference so that you can avoid either adding on non-steroidals, which are going to be probably much more toxic in the long run, or another DMARD, which the patient doesn't want, or changing biologics. That's my approach for one uncontrolled joint. Tune in tomorrow for more QD videos.